I'm seeing people rely on the ambient AI scribe tools, certainly. I can't tell you how life-changing they've been for many physicians who've really struggled to get their notes done on time and do documentation, and they've given hours back to many people's days. It's also a more enjoyable experience of practicing medicine for both the patient and the doctor. Like, you put your phone down on the desk and hit start, and then you actually just make eye contact with the human and talk to them and try to help understand their problem and help them address it.
Welcome back to Building with AI, the podcast where we explore how AI is reshaping industries from the people building the future. This season, we're diving deep into generative AI in healthcare. What's hype, what's real, and what's coming next? Today's guest is Dr. Graham Walker, an emergency physician and one of the leading voices at the intersection of medicine and AI. If you're a doctor, chances are that you've used MDCalc, the clinical decision support tool he co-founded, which is used by over 70% of US physicians every month. He also works on AI strategy at the Permanente Medical Group, helping integrate AI into one of the largest health systems in the country. And if that wasn't enough, he co-founded Offcall, a platform focused on physician career transparency, and co-authored the Physicians Charter for Responsible AI, a global declaration on AI ethics in medicine. In this episode, we cover a lot of ground, including how AI is being used in hospitals today, both predictive AI for patient risk assessment and generative AI like medical scribes, the real challenges of adopting AI in clinical workflows, what works, what doesn't, and what doctors actually want, why some clinicians fear AI will replace them, and why Graham believes AI should make medicine more human, not less. His vision for the ER of 2030, where AI helps doctors focus more on patients and less on admin work. If you've ever wondered how AI will impact healthcare, or if you're building AI for healthcare and want to understand the real challenges from a doctor's perspective, this episode's for you. Let's dive in. This episode of Building with AI is brought to you by Autoblocks, the company I founded to solve one of the biggest challenges in AI today, making LLMs safe, reliable, compliant, especially in high-stakes industries like healthcare. If you're a company building AI-powered products, whether that's a virtual health assistant, AI-driven documentation, or any LLM handling sensitive information, you know the risks. LLMs hallucinate, they leak sensitive data, and in regulated industries like healthcare, finance, and insurance, compliance isn't just important, it's a law. So what's the challenge? Most companies rely on manual spot checking and vague governance policies. That's not scalable. What you really need is a way to proactively catch AI failures before they happen, before an LLM suggests incorrect medical advice or violates HIPAA compliance. That's where Autoblocks comes in. We're an automated QA and compliance platform for LLM products, purpose-built for regulated industries. With Autoblocks, your team can run structured AI evals, detect risks before deployment, and enforce real-time guardrails in production, all while maintaining auditability and compliance. We're already helping companies like Hinge Health, Pelago Health, and others scale AI safely. If you're building AI for healthcare, finance, or any industry where safety and compliance matters, you need to be using Autoblocks. Go to autoblocks.ai to learn more or book a demo today. Again, that's autoblocks.ai, the trust layer for AI in regulated industries. Now, back to the episode. Dr. Graham Walker, welcome to the show.
Thanks so much for having me here.
To start, can you share a bit more about your journey? So how does an emergency physician end up co-founding a tool like MDCalc and leading AI innovation projects?
Yeah, it really comes from just spending a lot of time with computers myself growing up. I grew up with an Apple IIe and then a Compaq, and then I remember going to CompUSA and getting an Intel 486 processor and it being a really big deal so I could play better video games. And I remember the first time I heard speech coming out of computer speakers. So I've grown up with computers my whole life. My dad's a computer kind of tech guy as well. I knew computers before I knew medicine for sure, or knew that I even wanted to be a doctor. Even if I was not doing medicine, even if I was doing shoe sales or something, I probably would find some way to bring in technology just because it's fundamental to my life. I'm always dabbling in technology. And, I think it's a little bit of nature and nurture. It comes fairly naturally to me. Part of that is because I grew up with it, and part of it is, I don't know, it seems intuitive, and therefore I use it more because it's intuitive to me as well. It's a little bit of a positive feedback loop too.
Love it. And for those who aren't familiar, can you walk us through your career journey, maybe starting with your educational journey and how you ended up where you're at today?
Yeah, I'm originally from Kansas City. I'm from the burbs of Kansas City, but on the Kansas side of Kansas City, Missouri. And so I'm a Midwesterner. I have my Midwestern friendly values always. And then went to Northwestern for undergrad, studied social policy. So that really tends to be, if you look at anything I write and talk about, I always end up with like kind of a policy framework because that always shapes and influences how I think about the world, and really focused on health policy at the time. Took a year off from med school before med school and worked at this nonprofit called Physicians for a National Health Program. So, I mean, back in 2002, I was talking about single payer health insurance a long time ago. And then was fortunate enough to get into medical school here at Stanford. Spent 5 years at Stanford. Many of us do a 5-year thing where Stanford kind of encourages us to do some research. So did my 5-year plan at Stanford, went to New York City and trained at St. Luke's Roosevelt Hospital Center for Emergency Medicine and was a chief resident there my final year. Came back, did a SIM fellowship, so working with kind of mannequins and medical dummies to practice kind of high stakes scenarios like we see in the emergency department. And then I've been with the Permanente Medical Group, which is the Permanente part of Kaiser Permanente for KP Northern California. And I've been there practicing at our medical center in San Francisco for, since 2012. So yeah, 13 years.
Incredible. And you're still underselling yourself. Incredible experiences, even outside of what you had walked through. And I want to definitely dig into MDCalc at some point as well. But I'm curious if there was a specific problem in the ER that you had faced during your time there that you felt that technology could solve better, and that maybe was a convergence of the interests that you've always had in technology and your practice in the medicine space.
Yeah, Haroon, I'm always seeing problems that I want to solve with technology, and I just don't have the time to solve all of them. And I'm sure a lot of them are not actually good ideas. But when I was in med school, most things were still on paper. So we had very basic electronic health records most of the time that would do basic retrieval of basic information, but nothing that was the comprehensive electronic health records that we have today. At the time, I think we were mostly calling them EMRs, electronic medical records, and then health is a little bit broader of a term. And so because I was pretty facile with the internet and I understood how you could very rapidly retrieve information, often almost as fast as you could retrieve it from your brain, if you had good search strategies, I realized, hey, there's a lot of work that medicine is doing, and doctors and nurses and pharmacists, that I'm surprised we're all memorizing, and that could be done better. So that's certainly where the thought for MDCalc came from. MDCalc is a tool that is used by probably about 70% of US doctors every month, and we're used across the world. And it is for specific clinical questions that a doctor wants to have solved. At the time, all of these kind of scores and tools and decision algorithms were stuff that you memorized. And it was nuanced, esoteric stuff like, oh, is the calcium greater than 13.7? It was like, that was expected to be memorized. Or, yeah, sure, you could go look it up. But really, if you were a good med student or a good resident, you'd memorize these things. And I thought, oh, this is so silly. Part of emergency medicine is there's absolutely stuff in emergency care that must be memorized. Obviously, we handle life and death situations and have to think and triage and strategize rapidly. And you need to know the dosages of particular medicines that you need to give immediately. But that also introduces the concept of, okay, what don't I need to memorize? Med school is so much about rote memorization. You also don't understand why you're memorizing all these things. And then certainly over my career, I've also seen the downsides of trying to memorize things. I've had cases where I was working with a resident who thought they knew the dosage of a medicine that they prescribed maybe once or twice a year, and they had misremembered it. And so we had to change that dosage. And so there are actually ways that memorization can be harmful because human memory is not that great if you don't continue to use it and reinforce it frequently. There's actually lots of areas where it's actually better to look something up if you're not 150% confident in that number.
70% plus of doctors in the US on a monthly basis. That's incredible. How is the experience of building MDCalc and rolling it out and getting that sort of adoption? How has it informed you to think about AI in a clinical setting?
Oh, that's a great question. The first thing that I knew intuitively, but I don't know is super intuitive to people outside of those that actually practice medicine or are healthcare workers is how fickle we are about our access to technology. I will tell you right now, even the people that love MDCalc the best and give us 5-star ratings on all the platforms, if we force them to type a login and password, they would see if there's some other way they can get to the information faster. Any roadblock to obstructing a workflow just dramatically reduces the likelihood that a physician is going to complete that workflow. A lot of UX and UI people talk about people abandoning web forms or surveys, right? If you have 10 questions, you're going to have way more abandonment than if you have 5 questions in your survey. So it's really critical that you only pick the 5 most important questions because people will just give up. That's like 10x. That's a 10x stronger sentiment for physicians. And so a physician will, I think this is true with a lot of other medical references and even like internal hospital websites and internal tools and stuff like that. If it is hard to access the information, the physician will either give up or try to find another way to find that information, or will try to come up with a new workflow to figure out how to solve the problem that they're having. And I don't really know psychologically where that comes from. I think it's certainly a pressure to move and be efficient. And there's like an inertia with moving through a clinical workflow. And when that gets blocked, it almost like short circuits the doctor's brain or something. So that's certainly what I learned from MDCalc. And then I would just apply that to AI as well. If you don't have something that's easily accessible for the physician to use, or it's implemented in a poor way where you need a special username and password to access it, or you design it in such a way that it's hard for the physician to understand how it's used, or it's blocked by the hospital firewall, nope, abandon, move on. I'll do something else. I won't use this tool. If you do that enough times, the physician will say, I'm just never going to use this again. First impression is probably even more important for physicians.
As a tech leader in a major health system, how are you seeing AI used in hospitals today? And curious if you can give us an example of how AI is making a difference in either clinical care or operations in your hospital or any others that you're aware of.
Yeah, Haroon, there's a lot of answers to that question. Kaiser Permanente and our incredible division of research published a paper, I want to say 2018 in New England Journal, that was using predictive AI. So a machine learning model had, I think, about 90 inputs, and it's being used today with our patients to predict clinical deterioration. Someone is admitted to the hospital, they're doing okay on the medical floor, and then, hey, little something starts to happen that is often subconscious. It's not something that a human could necessarily pick up on, but there's just several variables that are starting to trend in the wrong direction, arguably before the patient themselves even knows, hey, something's going the wrong direction in my body. So that could be something as subtle as the white blood cell count for the past 2 days, it's gone up by 0.1. And normally we would chalk that up to just variation. And maybe the heart rate's gone up by 3, or maybe the blood pressure's gone down by 7, or that plus they're over 80 and their hemoglobin has dropped by 0.3 and they're on a blood thinner. Like all these permutations that you can do with machine learning and deep learning that humans literally just cannot do. Those are used in all of our systems and certainly have an impact on finding people that are secretly deteriorating clinically so that we can, move things back in the right direction. Sometimes patients need to go to the intensive care unit. We'll send them to the intensive care unit, find ways that we can right the ship and before things get to the point that their blood pressure really is low, or they become confused, or they look pale, or something that's more obvious to a human clinician. So that's on the predictive side. On the generative side, and that's usually how I split up AI in my head. We have the AI scribe technology that we use. We use a platform called a Bridge, and these tools are widely used by our clinicians to help them with documentation needs. I think there are a lot of other generative AI uses that would be super helpful around language translation, around some administrative filling out of forms. I think generally I have fewer forms in KP than in other types of health systems. And I think we will get to those as well, but there are some regulatory challenges in that space and obviously risk. And we have no interest in anything that's going to increase risk for patients. So they need to be tested, and we need to be thoughtful about what we're deploying and how we're deploying it too.
That's also something I would love to dig into. But on the generative side, is ambient listening by far the most common use case that's actually being implemented in practice in health systems today? Are there any other use cases on the generative side that you're starting to see pick up steam or that have achieved some sort of critical mass?
Ambient by far is the largest by far. There are health systems that have deployed their own internal kind of HIPAA compliant version of ChatGPT, essentially, right? They're running on Azure or something like that. They just allow their clinicians to just, hey, use this as much as you want. Probably, hey, receive some training first to understand the concept of hallucinations and how these tools can go wrong. But hey, let's make this available to all of our clinicians for two reasons. One, I think it can be, those LLM tools can be helpful in the right hands in the right circumstances. And then two, just for really data leakage risk as well. Giving doctors, nurses, healthcare workers an alternative to chatgpt.com or Claude.ai so that you don't run the risk of leaking PHI and end up with a HIPAA complaint and HIPAA violation that can be a big fine, I think is probably the other reason that I'm hearing about health systems offering that as well. But it also comes with financial costs too. Healthcare uses a lot of tokens and it's going to cost money too. So there's upsides and downsides, of course.
And what has been the reaction from doctors and staff so far? Are they generally receptive or skeptical?
I think doctors would love all the help we can get as long as it is safe. And it's mixed. I would say there are a lot of physicians, even here in San Francisco in the Bay Area, who have never used any generative AI tool. I was just looking up the data on ChatGPT usage in the US. I think there's 70 million US users of ChatGPT. The US is 330 million people. So most physicians probably have not really used ChatGPT or a large language model. Maybe they've used an AI scribe, which is using an LLM. But so a lot of people are naive, and there's certainly some fear that this is going to take their jobs, especially when you look at the lay press headline articles that say, oh, ChatGPT bested doctors. And so sometimes I'm talking people down from that. Don't worry, read the study if you really want to be curious, but that's not really what the study said. And then there's certainly another side that's, oh, is this something that could help me get through my day, help my patients, help me not make mistakes? If so, then yeah, we would love it. Doctors use tools every day. We use CAT scans and ultrasounds and lab tests and EKGs, and we use all these things all the time to help us make better decisions and make better diagnoses. And so if we can find a way to make this another tool in our arsenal, then great. It's similar in that I also know the risks and benefits of a CAT scan. So if we can teach physicians the risks and benefits of an LLM in the same way that I understand how CAT scans can either have false positives or false negatives or expose people to radiation that they don't need if they don't need the test, all this stuff. So I think if we can get to that level of understanding in healthcare, then we could see these as just another tool that could help us.
So you touched on a couple of things there. One is the fear that this technology is going to replace the need for clinicians. And then you also mentioned something along the lines of educating folks to use these tools appropriately and to not just utilize them, but also avoid over-reliance on the results from these tools. I'm curious to get a feel for how big this challenge actually is.
I think we need a lot of education. I will tell you that my long-term worry is that these tools will be so helpful that they'll upskill less skilled people and they'll de-skill highly skilled people, licensed healthcare professionals, because God, they're just so confident in their answers. Like we have social cues in humans that lets you know if someone's not sure an answer to a question, or just that they're thinking, or they're like trying to figure it out. Like we're on camera right now, but I'm trying to make eye contact with you. I'm pausing. I'm like looking up sometimes. Sometimes it takes me a minute to gather my thoughts. LLMs don't do that. They don't pause or they don't scratch their head. They say, that's a good question. They don't say, yeah, I'm not really sure. Can you clarify? They just start answering the question. It comes across to me as they're just very confident that, oh, damn, they must know the answer. They must be right because they're so willing to give you an answer. My worry is that medicine will just start using these tools willy-nilly and we'll have more trouble doing some of the critical thinking that it really is required in medical care. There will be multimodal models that can do video and stuff like that, but a lot of medicine, especially in emergency medicine, a lot of medicine is vibes. I heard somebody talk about, my generation would say, is like the gestalt of the patient, or like we talk about our spidey sense or our gut sense that there's something wrong with this person, or they just don't look right. The Gen Z version is vibes, but so much of understanding what could be if somebody has something really serious going wrong with them is related to your overall impression and looking at them. And that's not something, at least right now, that generative AI can do. It's great at parsing text. That's not the same thing as like actually talking to a person or looking through their chart and be like, God, this guy never sees the doctor and he's showing up in the ER today. Probably something really wrong with this person because they don't tend to seek medical care like ever, if that makes sense.
And for the subset of clinicians that are leaning into generative AI and they're starting to rely on it in some capacity or another, what challenges are these clinicians facing?
I mean, I'm seeing people rely on the ambient AI scribe tools, certainly. I can't tell you how life-changing they've been for many physicians who've really struggled to get their notes done on time and do documentation. And they've given hours back to many people's days. It's also, I think, a more enjoyable experience of practicing medicine for both the patient and the doctor. Like you put your phone down on the desk and hit start, and then you actually just make eye contact with the human and talk to them, try to help understand their problem and help them address it. In the AI scribe space, the thing that will be harder just because of human nature is it'll be harder for those physicians to like really deeply proofread the notes. Because if the notes are accurate 99.9% of the time, how can you really get at continuing to proofread a note at a fine level of detail? That's just human nature. That's not a fault of the AI scribe tools. That's not a fault of the human. It's just that's how things work. It's the same reason that occasionally we have really bad outcomes in car crashes and deaths with like automated self-driving tools or even just like lane assist stuff. If the lane assist is really good and you've driven 100,000 miles with lane assist and you have that level of trust in it, yeah, you probably spend less focus on the road as well. That's just human nature. You can't get away from that. And so that's the area where I'm seeing physicians relying on generative AI right now. But I would not be surprised if we start to see more usage of generative AI available to physicians. Healthcare is usually 3 to 10 years behind in terms of technology adoption compared to every other industry. I wouldn't be surprised if we start to see it more and more, but we're also pretty slow.
Yeah, I mean, what you mentioned there is such a challenging issue, and it has a lot to do with human nature. And do you have any ideas on how we can balance human expertise with the recommendations from these AI systems and in a way where we can benefit from them, but also vet the accuracy of their suggestions without having to do all the work anyway?
There's lots of tricks to force the human brain to stay engaged. TSA has the same problem. They have automated screening and stuff. And so I think what happened, what I've heard and read from the TSA stuff is occasionally they'll fake a knife showing up in a bag and not flag it to make sure the thing's paying attention. Or every so often you force the human to double check something or you give them an alert or something like that. So you can imagine in this AI, I'm just making this up, but imagine in the AI scribe tool, every randomly one out of every 50 times, the AI scribe tool tells the user, hey, I'm not sure if I heard you correctly for this portion of the thing. Can you double check this? And maybe it heard it fine, but you just like, you're forcing the user to stay engaged, or it, highlights a word in yellow or bold or something. And it's, oh, can you double check this? So there are behavioral tricks I think we could do. We all respond to the world working in better ways. Like CBC, like most blood tests are automated. If a CBC shows a low blood count or a high white blood cell count, I'm not going down to the lab and saying, can you double check this? I don't think it's right. I'm just accepting that number. And so that's the challenge, is like humans will just accept an automation because, and it's not like it's because I'm lazy. It's because, well, okay, great. I can accept that. I can spend my time with something else that's important too.
Yeah, and that's what the automation's there for, is to save you time. It almost feels counterintuitive to need to spend this extra time when the whole idea of the automation was to
automate things.
Yeah, automate things, unless you focus on other things. So what types of hurdles exist to implementing new AI tools, specifically with generative AI tools in the clinical workflow?
Yeah, there's lots. Otherwise, we would have adopted them already. Certainly, number 1, 2, and 3 is just going to be privacy and data access. I think health systems both have a fiduciary, an obligation to maintain their patients' data and keep it private and make sure it doesn't leak anywhere. I think health systems also all have some recognition that like their data is highly valuable and that people want access to it because it has value outside of the actual whatever generative AI tool. Like you could build an AI tool and also scrape the data. That would be very valuable. And so I think health systems are appropriately concerned about I don't know if the right word is bad actors, but just like people that are looking to have access to their patients and their healthcare providers to build data. I think especially the tech world doesn't have the best reputation of taking data privacy seriously. And so many of these companies are coming from the tech world that has generally quite different cultural values to healthcare, right? Move fast and break things kills people in healthcare. And so there's a reason that healthcare is slow to adopt things. There's a reason that healthcare is slow and sometimes painfully doesn't feel like it's innovative. And it's like stability and dependability in a healthcare system is actually a value. It's actually an important thing. So that's like the biggest one. And then number 2 would be probably like safety/accuracy. Generative AI has made drastic improvements with hallucination, confabulation stuff. It's remarkable. In like 2.5 years since ChatGPT came out, like things are remarkably better. And I actually have to work a bit to get these models to hallucinate now. Like I have to trick them, which is like a really good improvement. You can imagine 1 out of every 1,000 times it hallucinates and gives you the wrong answer or the wrong dosage of a medicine, when 999 other times it's accurate. Like how much is a human being really going to double check every single number? So that's certainly a challenge. And then certainly cost as well. Healthcare has a really thin margin frequently. And now you've got another mouth to feed. Now you've got a technology partner that is going to want to charge for their services and generate a profit for themselves as well. So those are probably the biggest 3, I would say. The other stuff, like the education piece, we can educate physicians on that. That'll take time and energy, but that's doable. Bricker says that physicians are autodidacts. Like we teach ourselves, we learn things. You can't not learn things while you're an attending for 30 years because medicine changes. New technologies, new drugs evolve, new standards of care are created. And so you have to adapt. You have to be able to understand how to teach yourself new information and adapt. And doctors are fine with that piece. That's relatively an easy piece.
You touched a little bit on ethical AI in your last response there, and you've been a leading voice for ethical AI. In fact, you helped author the Physicians Charter for Responsible AI. And what are its key principles for using AI in patient care responsibly?
Yeah, I created it with the help and the funding and resources of MDCalc. I was talking with Josini, our doctor, and ChatGPT came out like right around the time he had his daughter. I think I was maybe the first person to show him ChatGPT because he was like so busy with his daughter. And I was like, hey, look at this thing. This is insane. Joe and I are great partners together because we complement each other really well. In this case, not always, but in this case, I was super optimistic. I was like, this is so cool. Look at all this crazy stuff you can do. And Joe was like, oh my God, what is this thing going to take over the world and medicine and what? And I just brought a human life into the world. And what kind of world are we entering? We didn't get a sense from what we were seeing online that anybody was really paying attention to this space. There were a couple groups doing stuff. Even the National Academy of Medicine had put together some very academic, I think, panel or committee, but they were like, oh yeah, the first information will release in 2025 or 2026 or something like that. And we're like, that's 3 years away. The AI is going to take over tomorrow. We need to rally the troops. Joe and I felt like we at least need to say that we tried. Hey, let's put together a bunch of doctors and see if anybody else cares about this and thinks this is a concern. And so I just put out a call on LinkedIn, and I think 9 or 10 other practicing physicians from around the world, mostly in the US, but a couple international. And we all started to talk about it and divvy up the workload. And we said, okay, let's focus on values and then maybe come up with some rules. Have to keep things simple, like practical to a fault. I really wanted to keep it like, hey, let's make something that if you're a health system, you could like download this thing and read it and have a general sense for what should matter, what should be important. And really the key value is keeping the physician-patient relationship at the center of everything. And if AI wants to come in and consult and help, that's great. But that it seemed like a really bad idea to have an AI chatbot just engage with a patient without a doctor or honestly any other healthcare professional, whether it's making a diagnosis or coming up with a treatment plan. Like it seems like a bad idea to not include the physician in that space. And, is that protectionist? Sure, probably a little bit. I don't want to lose my job to AI, but at the same time, I actually think it is particularly dangerous to not have a human being that actually is trying to help another human being in the room. These AI bots they're mathematically, they're just predicting the next word in the sequence. And that, I don't know that that's really the same thing as what I'm doing when I'm practicing the medicine and trying to help a patient. Fundamentally, maybe it is, but I don't know. I don't think so.
For what it's worth, I don't think so either. I think there's a lot more to healthcare than just the decisions and answers that you get from some of these tools. And since you have put together the charter, I'm curious how your thoughts have evolved.
I think they've stayed pretty consistent again, because we really focused on the values, having the values drive what we called the 10 rules of the road. And then we wrote a chapter for each rule, and it's available at physicianscharter.ai if you want to check it out. So I don't think they've changed much. I guess the thing that I would add that I don't know that we included is just this idea of judgment being a human level task that I don't know that an AI tool can do. Like when you're deciding to order a test or to do a thing or to not do a thing in medicine, you're making a judgment call. And that is based on your own experience, your understanding of the patient, your understanding of the disease process you think they may or may not have. And I don't know that a piece of software that does not have a body and cannot die or have morbidity or disability or things like that, I don't know if a machine can really ever do judgment. The example I give is, I don't know that we will ever have a machine saying, yeah, we're going to cut you open. We are so sure that you have appendicitis that we're just going to say, yeah, you're getting surgery. I would imagine a human is always going to want another human just making that particular decision. Now, a machine, a predictive AI model could say, yeah, there's a 99.9999% chance that this person has appendicitis. Or it can maybe it even rounds up and says 100%. But the decision, the judgment call to say, okay, and because I agree with the assessment of appendicitis, I'm going to risk your life by literally opening your body and taking a part out of it. I think that's a judgment call, and I would hope that remains with humans.
Yeah, I would hope so too. So, I want to shift gears to talk a little bit more about the work that you're doing at Offcall. So, between your work in Offcall, and would love for you to talk about that a bit more as well, and your day to day in the ER, you're obviously very attuned to physician burnout and workflow. Do you see AI as something that's going to help reduce burnout by taking over many tedious tasks? Or do you worry that it might add new frustrations for doctors and potentially more work that was unexpected and undesired?
I think AI has the potential to maybe do both. And again, it's going to depend on how human beings and health systems deploy the AI and maybe even like the expectations that they have if a physician has access to the AI. My worry is that we will continue to view healthcare as just another type of capitalism, that, healthcare should be just the same thing as selling donuts or repairing shoes or being a consultant, that like it's just a transactional exchange of goods and services for money. And if you purely look at it that way, then you could very easily say, oh well, the AI is saving 7 minutes per day for a doctor that uses it. So yeah, we could sneak in an extra patient or two every day. And so if it's purely looked at as like, oh well, you're 3.2% more efficient, you can see 3.2% more patients. That's going to burn people out more, and that's hopefully not the intent of the AI. So it could go that way, but I'm hopeful that as more physicians are speaking out about how they would want things to work, and patients as well, are speaking out about how they would want an AI to help or not be involved in their care. I'm hopeful that AI tools can help doctors get through their day, even be like a bit of an objective arbiter for maybe health systems, or if there's a CFO that's like, they're more efficient or I'm paying too much for this. I always think of the example, people send me screenshots and, you know, Elon, who I'm not a fan of, has his Grok AI large language model, and like Grok stuff about Elon, and it's not the most supportive tool for Elon. So you could imagine a world where like um, an AI bot is actually telling a CFO, like, it actually is probably not a good idea to try to make your doctors work harder.
And can you just share a little bit about the motivation for starting Off Call? And are these some of the discussions that are coming up quite frequently with some of the community members? Is this idea of unintended burnout from AI tools?
Yeah, it's coming from a lot of different directions. I think AI potentially is less of one, but there are a lot of physicians leaving medicine. There are a lot of physicians burning out. A lot of people just, hey, I'm done. They throw up their hands. I quit. I don't care. And this is not just people who've been practicing medicine like me for 17 years. This is often people who've been practicing for like 2 or 3 years. They finally made it. They jumped through every single hoop. They're board certified. They have a attending job where they're sometimes making $300,000, $400,000, and they still are not happy with the workload or the work environment or whatever it is. And no one is really talking about this. Part of the inspiration was the media is not talking about this and doesn't really seem to care or is not interested. The government, whether it's at the federal or state level, not talking about it, doesn't really care that this is a problem. And so I kind of came to the conclusion that, like, well, nobody's going to fix this. And so I think if anybody's going to fix it, it needs to be doctors. So I started a company with my co-founder, Jake, and really the idea is to try to improve. I mean, it's a very nerdy, data forward idea to address burnout and problems in the house of medicine, but it's like, hey, let's give people access to more data, not just about their salary, but like how many patients they see per day, how many patients they see per hour, do they get maternity or paternity benefits, all this data that doesn't currently exist. We're building a data set that hasn't existed yet. And just a sense that like transparency is actually like a really good way of uh, giving some leverage back to individual physicians who feel burnt out and not heard, and are now increasingly employees of somebody else, often somebody that's not a physician, who's their boss and who's telling them, in some ways at least, what to do, how to practice, things like that.
Is part of the idea that by quantifying the different variables and factors that contribute to burnout, you're able to factor that metric or set of metrics in some sort of equation or decision that is being made by a system.
Yeah, you can have two jobs in the same specialty, seeing maybe the same number of patients per hour, get paid the exact same amount of money. And one can be the best job you ever had, and one can be the worst job. They could be in the same city. And so there are so many factors, sometimes way more important than salary or income or compensation, that actually lead to burnout and moral injury. Those could be related to like staffing levels or boarding in the ED for emergency physicians. It's also kind of different for every specialty too. A cardiologist probably doesn't really care about the number of boarders in the ER because they don't really spend time in the ER that much. And so every specialty has particular things that's going to make them more exhausted and less satisfied and less happy and more likely to leave medicine or leave that health system. It's expensive to onboard physicians and train them and teach them and then have them leave as well. So I think there's plenty of win-win-win available in the system.
All right, Graham. So I want you to put on your imagination hat and step into year 2030. Describe what the emergency department looks like with AI everywhere in an ideal world.
I love this question. Yeah, the patient has already given me at least part of the information of why they're coming in to see me en route. They're having some chest pain or some belly pain or something. They're, not unconscious or something. Yeah. So the patient's already given me a lot of information because they've talked to their phone to my chart or whatever. And then it's made a summary ahead of time. So when they arrive, I've already got that information and I'm really just editing and confirming that. And then the EHR is also combining that with the information that the EHR already knows about them. It knows they just had their appendix out 3 days ago and were discharged 2 days ago. And they have an appointment tomorrow with their surgeon, right? That's kind of all on the generative side. I could see on the predictive AI side, there's a model that's saying based on their vital signs and how long the surgery took and that they had a gangrenous appendix on pathology. All of these factors are saying, hey, Graham, Dr. Walker, there's a 78% chance that this patient has a post-op complication. They may have an infection. They may have an abscess in their abdomen, something like that, right? And that could help me guide my conversation with the patient and say, hey, let's confirm all this stuff based on my clinical experience. I've reviewed all of your stuff. The AI model is saying you may have an infection in your belly. And I personally agree with you. I've been an ER doctor in 2030, it'll be 21 years, 22 years. I've been an ER doctor 22 years. And, I agree with the AI. I think this is a concern. What I'd like to do is give you some IV pain medicine, give you some nausea medicine or a couple blood tests. And I think we probably should do a CAT scan. And this is all being documented by the AI as well. So by the time I get back to my computer, I'm just confirming all those orders that I told the patient about. The nurse has drawn the tests. Radiology knows, we got another CT scan we need to prioritize. And then the AI is helping the radiologist decide in what order to look at the CAT scans. And they say, it looks like this one may have an abscess on it. So I'm seeing the AI saying, it looks like there's 5 normal CT abdomens to read in your queue. We think the AI thinks it's normal, but hey, this one looks like there's an abscess. So we're going to move that to the head of the queue. So it reads my patient study first. And then the radiologist confirms there's an abscess there. The AI contacts the surgeon and generates the summary of my note, the radiologist note, the prior history, sends the note to the surgeon. So the surgeon knows exactly what's going on with the patient. There's less back and forth between me as well. And then the patient gets that information as well in patient-friendly language too. Hey, yeah, you do have an intra-abdominal abscess. And then the patient can have their little patient chatbot that explains how those are usually managed and what the recovery course is and why this happened. Any question they have, it can help answer that question as well. And if there's a question I can't answer, now I've got the free time that I can swing by after the CAT scan and say, hey, how are you feeling? Do you need more pain medicine? How are you doing? Do you have other questions that I can answer? Voila, boom, one patient down.
Wow. I feel like that I have such a vivid image of what you just described there. I really appreciate you walking me through that. Given all that we've discussed, I'm curious, Graham, what advice you would give to clinicians who are nervous about AI or to tech innovators who are eager to build the next great healthcare AI tools? We're going to have folks in the audience that are practicing clinicians, and then we're also going to have folks that are technologists. So feel free to share messages to either one or both.
Dear clinicians scared of AI, I too was scared of AI when I first started to learn about it. I was both excited and scared. And the deeper I get into it and the more I understand it, the more I feel more confident about it because I actually am able to create like a thicker line in the sand where it's like, okay, this is stuff that AI will not be good at and will never be good at. And this is stuff that AI could actually help me. So if you want to overcome that fear, learning more about AI and how it works and how it doesn't work and when it's going to fail or not be helpful can allay those fears as well. We need more physician voices speaking out about what they would want from AI. So that same example that Haroon, you just asked me about what I would want in my perfect ideal emergency department, like we need a rheumatologist saying what rheumatology would want. I don't know. I barely know what a rheumatologist does at all. We need people from every single specialty saying what they would want in an ideal world in 5 years. What would help you and how could it help you and how could it help your patient as well? And then for technologists, I would say specifically in the health space, thinking of your product as a partnership with a health system, or you could think smaller too, just think of one specialty or think of a medical group or a doctor's office. I mean, you go super small. Think of this as a partnership of what tools you could build that could then help that person. I think the vendor like relationship where you're just pitching a product that you're selling and you're hoping that somebody buys it and obviously hoping that that solves their problem, I think is a harder relationship. And I think the more successful relationships will be relationships where it's actually like a back and a forth and the health system or whoever is going to have to pay you to use those services because it's going to cost you money. And maybe there's some equity or some shared co-development that you could do as well to support both sides of it. But I think viewing things as a partnership with a healthcare professional is going to go a lot further than like, hey, we're just selling you this service and oh, that's a good idea for a feature, but yeah, we don't have that right now, but we could add that if you buy our product. I don't think that's going to be as successful, especially when we have a ton of consolidation in healthcare and, fewer and fewer hospitals getting bought up by larger and larger systems too.
I would be remiss if I didn't ask you about how you draw that thick line in the sand. I'm curious, very briefly, how you might define the types of skills that are unlikely to be automated by AI and that might increase in value, so to speak.
So we talked about judgment a little bit and kind of being that person that decides that information because that comes with risk. That will always come with risk. And Anthropic just put out a paper yesterday that evaluated how their users are using tools and which tasks are involved. And it's really interesting. You can go on this website called ONET Online, which I'd never even heard of before. And it's some government website where somebody has gone in and written down all the tasks you do. And I was like, okay, they're not going to have ER doctor. And they totally had ER doctor. And they had like 17 tasks identified. I was like, damn, this is what I do. It was really interesting to see my work that I think of as very individualized and it changes every day, described in very task-oriented ways. I think the areas that probably will not change, at least in the 5 to 10 year horizon, procedures. AI might help support you with procedures either through education or maybe some AR goggles or something like that. But I don't see procedures going to AI anytime soon. And then I guess the other area of drawing a line is just like being a human and talking with a person about serious things that happen to the human body. It's one thing to Google and see like, oh yeah, one of the things that could be happening is cancer, which you always Google and it always can be cancer. But it's another to have a human being sit you down and look you in the eye and say, hey, I'm really worried that this is cancer. It's a whole different emotional level. It's a whole another level of seriousness. And you don't stop there and just say, yeah, I think it's cancer, period. You say, we're going to figure it out together. I know that's a really scary thing to hear and to say. And here's what we're going to do next. We're going to do a biopsy. I've already set that up. Blah, 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 all the other steps that take this from a transactional thing to actually a human thing. There's totally a branch of the multiverse where AI actually makes medicine more human and more compassionate when we've gotten so far away from that due to often like the corporate and capitalist side of medicine and then just like the digitization of medicine as well.
Yeah. And let's hope that we strive to move down that branch. I think that
Yeah.
that is the right branch for us to move down. Graham, thank you so much for taking the time. It's been a pleasure. And
Yeah.
where can people find you and Offcall and any other links that you might want to share?
Just so that I could get my Blue Sky handle, I bought the domain drgrahamwalker.com so that I can get my Blue Sky handle. So I hang out on LinkedIn and Blue Sky, and then it's offcall.com and mdcalc.com.
Excellent. Graham, it's been a pleasure. Thank you so much.
Thanks, Haroon.
This episode of Building with AI is brought to you by Autoblocks, the company I founded to solve one of the biggest challenges in AI today, making LLMs safe, reliable, compliant, especially in high-stakes industries like healthcare. If you're a company building AI-powered products, whether that's a virtual health assistant, AI-driven documentation, or any LLM handling sensitive information, you know the risks. LLMs hallucinate, they leak sensitive data, and in regulated industries like healthcare, finance, and insurance, compliance isn't just important, it's the law. So what's the challenge? Most companies rely on manual spot checking and vague governance policies. That's not scalable. What you really need is a way to proactively catch AI failures before they happen, before an LLM suggests incorrect medical advice or violates HIPAA compliance. That's where Autoblocks comes in. We're an automated QA and compliance platform for LLM products, purpose-built for regulated industries. With Autoblocks, your team can run structured AI evals, detect risks before deployment, and enforce real-time guardrails in production, all while maintaining auditability and compliance. We're already helping companies like Hinge Health, Pelago Health, and others scale AI safely. If you're building AI for healthcare, finance, or any industry where safety and compliance matters, you need to be using Autoblocks. Go to autoblocks.ai to learn more or book a demo today. Again, that's autoblocks.ai, the trust layer for AI in regulated industries.